So thank you very much for that kind introduction. And while the slides are just loading, also your thanks and support for this study. Because, of course, I remember you very kindly came and spoke at one of our investigator meetings. So I'm delighted to present this study at the European Society of Intensive Care Medicine Congress. People may recall that last year we had hot off the press the preliminary findings from the BREATHE study, and I'm now very pleased that the paper has just been published online in JAMA. The aim of the BREATHE study was to evaluate the safety and effectiveness of non-invasive weaning as a strategy to aid liberation of patients from invasive mechanical ventilation. The study was funded by the National Institute for Health Research Health Technology Assessment Programme and supported by the Intensive Care Foundation in the UK. I stand here as one of a team of co-investigators that made a full contribution throughout the study, and indeed to the 52 intensive care units around the UK who contributed patients to the study. The context for the trial was that the amount of time that a patient spends on a ventilator, particularly receiving invasive ventilation, is related to worse outcomes. The longer a patient's invasively ventilated, the greater risk that they'll suffer from morbidity and mortality. And there had been a number of small trials in the preceding 20 years that had looked at early liberation onto non-invasive ventilation, and they were summarised in the Cochrane Systematic Review in 2013. This review and meta-analysis identified the potential for reduced mortality, a reduced rate of reintubation, reduced ventilator-associated pneumonia and tracheostomy, and also that patients would spend less time weaning and require less invasive ventilation, leading to knock-on effects and improvements in hospital and intensive care length of stay. The challenges of the work that existed prior to our study were that there were a number of small trials conducted over a course of 20 years, and the majority of studies actually predominantly contained patients with COPD, many of whom now would receive non-invasive ventilation as a tool to prevent the requirement for invasive ventilation. The remit for the trial, or the scope of the trial, was set by our funder, who wished to determine the clinical and cost effectiveness of non-invasive ventilation, and we tackled it as a pragmatic open-label randomised controlled trial where we recruited adult patients who had been ventilated for more than 48 hours and had failed a spontaneous breathing trial. We had, our intervention was protocolized extubation onto non-invasive ventilation, and our comparator was protocolized invasive weaning. And the reason for protocolizing both the non-invasive and the invasive arm was data which suggests that the simple act of protocolization in itself may improve outcomes. Our primary outcome was time to liberation from ventilation, and we had 90% power to detect a 24-hour difference in outcomes. I'm going to walk through the outcomes over the course of the next few slides, but to just summarise them in one place. Our primary outcome was time to liberation from ventilation, and then we had a number of clinical efficacy, safety and patient-focused outcomes. Patients on our intensive care units were screened daily and assessed using the Walsh criteria for the readiness to wean. And when considered ready to wean by the treating intensive care team, they'd undergo a spontaneous breathing trial. And the published literature suggested that the majority of patients would actually pass the spontaneous breathing trial. We use the international consensus criteria to define spontaneous breathing trial failure, and these contained physiological variables, those relating to gas exchange and arterial blood gases, as well as a clinical assessment of the patient's readiness for weaning. We randomised patients, as alluded to, either for the sequential reduction in pressure support on a 2-hourly basis as tolerated in the invasive ventilation arm, or in the non-invasive ventilation arm. After a period of recovery, patients were then extubated and were then provided respiratory support using a non-invasive ventilator. Again, if tolerated, patients were given breaks and opportunities to come off the non-invasive ventilation. We randomised 364 patients, and we had equal numbers of patients in both of the groups, and we had fairly complete follow-up, certainly to the point of the primary analysis. Patients were randomised throughout the day, with the majority occurring between 9 o'clock and 4 o'clock in the evening, and patients were randomised 7 days a week. In terms of the baseline characteristics, these were reflective of the population of patients treated in intensive care in the UK, and they were well balanced between the two groups as summarised in the slide here. In terms of the primary cause for admission, then pneumonia or respiratory failure was the commonest cause in both of the groups, with post-operative respiratory failure being the third commonest, and cardiac impairment being the third commonest. Non-respiratory infections representing about 10% of admissions. In terms of the baseline physiological measurements, patients were on an average or a median PEEP of about 5 centimetres and requiring a median pressure support of 11 centimetres of water. You can see here that a proportion of patients fulfilled the oxygenation criteria for acute lung injury or for the mild form of ARDS. Most patients in failing the spontaneous breathing trial failed on one or more criteria, so 80% of patients failed on more than one criteria, with just 20% in each of the groups failing on a single spontaneous breathing trial criteria. In terms of moving to the trial outcomes, and to remind you that the primary outcome was the proportion of patients that were liberated, or the time to liberation from ventilation. As we show in this slide, there was no overall difference in the time to liberation from ventilation, as shown here. We undertook a sensitivity analysis that also accounted for the proportion of patients that died during the weaning process. And as you can see here, similarly, there was no significant difference in the proportion of patients who were liberated or died between the non-invasive and the invasive group. The trial protocol was well implemented, and I think, as you can hopefully see here, that there was a higher proportion. 98% of patients in the non-invasive arm were indeed successfully extubated, and you can see in the plot on the right-hand side that patients were extubated earlier than in the invasive group, and that's as you would expect for an intervention that is randomising patients in the non-invasive group to early extubation. Again, as we might expect, because we were swapping patients from the mode of ventilation from invasive to non-invasive, that we did, as we would anticipate, see a reduction in the amount of time that the non-invasive group was spending requiring invasive ventilation days. So there was a median difference of 3 days and a median difference of 1 day in the total number of ventilated days. One of our post hoc comparisons was to look at the amount of sedation that patients required, and we noted a reduction in the amount of sedation that patients required during the weaning process. We also noted a reduction in the proportion of patients that received respiratory antibiotics for presumed respiratory tract infection. Patients spent on average about 2 days less in the intensive care unit compared to those in the non-invasive group. In terms of adverse events, we saw no overall difference in the rate of re-intubation or tracheostomy between the two groups, and mortality at a variety of time points, as I'll come on to in the next slide, was no different between the groups. We also saw no significant difference in the proportion of adverse events sustained as part of the weaning process. So here's the slide that tracks patient mortality up to 6 months, and there was no overall difference or no significant difference in survival at any of the time points that we evaluated. We also tracked patients' health-related quality of life at baseline and then through to 3 and 6 months. And it's a very busy table here. I think the main message to take away is that there was no significant difference in health-related quality of life related to the mode of weaning. We undertook 2 a priori defined subgroup analyses, and we found no interaction according to the patient's underlying COPD status or whether they were an operative or post-operative patient. So in terms of summarising the key findings in our trial, early extubation to non-invasive ventilation compared to protocolized invasive weaning led to no difference in the overall time to liberation. However, a higher proportion of patients were extubated. They spent less time requiring invasive ventilation and a little bit less time in total ventilator days. There was a reduction in requirement for respiratory antibiotics and reduced intensive care days, and there was no overall effect on mortality. So I invite you to review the paper, which I think has just gone online with JAMA, and I conclude that protocolized weaning with early extubation to non-invasive ventilation compared to invasive weaning did not significantly shorten the time to liberation from all forms of mechanical ventilation. Thank you for your time and attention.